So PET-guided treatment in lymphoma. What's the role of PET today in lymphoma? So we should talk about different situations. We have classical Hodgkin's lymphoma on the one hand and the non-Hodgkin, especially the aggressive non-Hodgkin lymphoma patients on the other hand. For Hodgkin lymphoma, PET now is really established as standard of care, I would say all over the world, because it allows to guide treatment in an individualized way. We can't predict the outcome of our patients upfront when we start treatment. But what we can do is, for example, after 2 cycles, if you either start with ABVD or with escalated BA-COP, ABVD is the RETHL trial, escalated BA-COP, the HD18 trial. If you do your PET scan after 2 cycles, and then you see a good response or no response, and then you adapt your treatment, you either intensify treatment or reduce treatment, then you can individualize the treatment strategy for each patient, so each patient receives as much treatment as needed. And we know, for example, for the German Hodgkin study group, which I represent here now, that we tend to over-treat patients to be on the safer side in terms of efficacy, which on the other hand means that many of our patients do experience side effects which could be avoided. And now with the use of PET, we administer only 4 cycles of chemotherapy within 12 weeks. This is the HD18 trial, and thereby really can reduce the burden of treatment for these patients. In aggressive lymphoma patients, this is very interesting. This is a development that has been led by the so-called PETA consortium. They looked for the meaning or the prognostic and predictive meaning of the total metabolic tumor volume at baseline, because it's obviously much better to predict the outcome at baseline and to adapt your treatment strategy upfront than during the course of treatment. It would be perfect to have a good marker at baseline. And what they found is that the total metabolic tumor volume, as determined by PET, is highly prognostic for the outcome. And it has just recently been published in the JCO. And this allows now to select patients with a very high risk for treatment failure, which is not completely, but which is a markedly different patient population that we know from the IPI, so the established risk score. So this really adds relevant information to guide treatment strategies and will allow to tailor treatment intensity also in aggressive lymphoma to the patient's need, which I think is, given the toxicity of our treatments, really important.